Where's my pointer here? Well, that's good. That's a good start. Certainly, we find this is a very challenging aspect of our work. And what we want to do today is really just to enable you to be aware of some of the ethical frameworks and theories and how they relate to common end-of-life issues that we deal with day to day in our daily palliative care practice. We will discuss briefly themes of autonomy, dignity, futility, truth-telling, and talk about life-prolonging treatments. These kind of issues are things that are not decisions that are not made by one person, that we work together as a team and we have a lot of discussion and thought around them. So I'm hoping that in our session today we'll have a wee bit of input and discussion around these things as well. This is very challenging and probably the most challenging aspect of our work, and often much more difficult than even managing complex symptoms. And it's very individualised, each person. So past this signpost, there's not a clear left turn or a clear right turn. It's very different for different people. For some patients, the left turn will be the right. For some patients, the right turn will be the right. And it can differ for patients as they go along the journey of their illness. So for a patient, it may be right to turn left now, but further down the journey, it may be appropriate to turn right. And that makes me...
Sorry, Tracy, I think there's some technical hiccups, as you can see, and we're just getting connected on again to our 3 stations there, so apologies for this, but we're hopefully back on again.
Okay. So sometimes it's right to go one direction, and sometimes the later part of the journey of illness, it's right to go a different direction. And that makes me think of a lady that we looked after recently who had a fracture, wasn't in a lot of pain with it, and the anaesthetic risks were great. So her decision was not to have surgery. A few weeks later, her fracture got worse, her pain was excruciating, her decision was completely different because the balances and risks were different at that point, and the decision was different. And we've found that in decisions that we all make in daily life, in our personal lives as well as our professional lives, and they can be very challenging. And I think one of the most challenging aspects of it is that we can do this as well as we're able to, and sometimes we don't get it right, and it's hindsight that gives us the insight that we don't have when we're going through it. So we had a patient recently in hospice, and we did it beautifully. We looked at his risk of clotting, his risk of bleeding. We weighed it up with him, we weighed it up with his family. We made a decision to stop his prophylactic Clexium because his bleeding risk was too great. 1 week later, he developed a large DVT. We couldn't have predicted that. If we went back to the same situation, we'd probably make the same decision. But it just highlights the challenges and the weighing up and the risk and benefit, and how this is so individualised for every patient. So there are a lot of common issues that we deal with day and daily that are related to ethical issues. We will talk about some of them in a wee bit more detail today, but every day we're asking questions about the appropriateness of whether the patient should have IV fluids or not. And occasionally we'll be talking about artificial nutrition as well. We try our best to let the patient be responsible for making their own decisions when they're able to do that. And sometimes that can go against our better judgment. Just this week, we are allowing a patient to make decisions that we wouldn't necessarily agree with, but the patient has capacity to make them, and we have to give them the opportunity to do that. But we do need to assess, as Rosemary said, about whether the patient has capacity to make those decisions or not. And with patients who don't have capacity, we work together with what we know of what the patient wants and what we think are the best medical decisions to help make decisions that are in the best interests of a patient. Because there's no clear right or wrong here, we can have conflict within our teams about what's the right thing for the patient, and often that's at the very end of life, and often that's around how aggressive our management should be in the patient in the last days of life, and that's something that we need to work through as a team and resolve together. We all have very emotive cases, very frequently for many different reasons. Thankfully, equity and rationing is not something we have to do in terms of medications, often in palliative care, but there are other things that we do need to address. We have a hospice with a limited number of beds. We often have many patients who need to go to it, and we have to make decisions as to who should have those limited beds, and that can be difficult. Families can be challenging when everybody's well and healthy and things are good, and whenever somebody is terminally ill, families can be even more challenging. And that's often around end-of-life issues and how aggressive we should be in treatment as well. And you know, we've all had the families who fly in from far away and want everything done whenever we're reaching a conclusion that the patient's dying, and that can make things very difficult, and that can be a difficult thing for families to move on and live with for a long time. And a lot of those decisions can be around treatments that we think are futile, but we need to weigh up what is right for that patient, and that can be things like resuscitation, like withholding treatments, and Caroline will talk a wee bit more about those sort of things a bit later in the presentation. But ultimately, the patient is our priority and patient safety is paramount. So it's not black and white.
Can I just apologise to Fiona after her beautiful, sensitive, gentle talk? I put that up, so I'm sorry, but I couldn't resist. It was very difficult to find something decent that I could put up, so that was the best I could do. But how do we navigate? How do we find our way through the 50+ shades of grey that we encounter with our patients? Unfortunately, there are some traditional ethical theories, some more modern ethical theories that can help us to give a bit of a structure in how we make these decisions. So, traditional ethical theories. Deontology. The deontologist is somebody who's quite moral, who sees things quite black and white and actually says things can't be negotiated. So if I was a deontological doctor and I had half an hour and I had 5 patients, I could see one excellently, or I could see 5, but it would be pretty average care. Well, I would say it's not acceptable to give anything other than excellent care, so I will see 1 patient, and it's not my fault there aren't the resources for the other 4 patients to be seen properly. So that's what my belief would be. But sometimes that's not very real world, and we don't always think like that. So some people have a different view. They have a utilitarianistic approach or a consequentialist approach. So they look at, does the end justify the means? So they would say, well, actually, 5 people need a doctor, so they'll all get seen to a fairly reasonable standard. It won't be brilliant, but it'll be okay. And then there's a third. There's the virtue theory, and these are really good people who actually say, well, no, I'm going to find a way that all 5 patients can get excellent care. So that's one set of ways to think about it. And the first time I learned about this, I was doing my diploma in Cardiff, and they explained it in an even simpler way, which I really liked, which asks us to look at what our moral philosophy is. And often we all have lots of views about speeding. I've had a long and scattered history with the police and speed cameras, so I have to say that first. So the deontologist says 30 miles an hour, that's the maximum. I'm going to follow the law. The law is really important. I'm never going to go above that. So in the room, anybody deontological about speeding? No. So the consequentialist says, well, hold on a wee second. I've talked to a lot of people. I know policemen, and they say that if you do 10% over the speed limit plus 1, you'll never get done. It's not true. I got done for 33. But they will say you can go up to 33 miles an hour and you won't get done before 34. So who would be more in that approach? Yeah. And then the person who's the virtue theory will say, well, look, 30 miles an hour is normal. If it's an absolute life-threatening emergency, I'll push it to 35. Anybody have a virtuous approach? Oh, oh, lovely. Okay. So if we make it a bit tougher. So you're trekking in the Andes and you come across a hostage situation. And there are 20 villagers who are being held hostage. And there's a guerrilla leader and he says, right, I'm giving you the choice. You're in charge. If you shoot one of those hostages, I'll spare the other 19. But if you refuse to shoot, then all 20 will be killed. So what are you going to do? If you're a deontologist, you're going to say, no, I'm not going to shoot. It's always wrong to shoot an innocent person, and it's not my fault if 20 die, I'm not killing them. So does anybody feel like that? No. Okay. The consequentialist, and often people in healthcare are consequentialists, will say, well, maybe I'll shoot 1 victim, but I'm going to save 19 people, and that's huge, so the greater good is served. Anybody feel like that? 1 at the back. Okay. Oh, you're great. So then the virtue person says, well, no, actually, I'm going to look at how my action to kill anybody would reflect on my character, and I'm going to find a better way to save all 20. So who's virtuous? Everybody. Brilliant. Okay. Okay. But actually, what we tend to find in the real world and in real life healthcare is that if we're making an individual decision for an individual patient, then we will be quite deontological in our approach. We'll give the best care that we possibly can. But if we have limited resources and if we want to look after a lot of people, then we may be settling for a slightly lower standard of care, but which more people receive. So that's the old-fashioned traditional ethical theories. And then we can move into the principles which we're probably a lot more familiar with of biomedical ethics. So autonomy, non-maleficence, beneficence, and justice. So autonomy is that we involve our patients, we respect their decision-making abilities, we recognise they have capacity, to come back to Rosemary's lecture, and we involve them and we involve their families. Non-maleficence, we don't harm our patients. Beneficence, we try to do good. And justice, we balance our patients' needs with the needs of other patients on the ward and the needs of people in the bigger society. And sometimes if we use these principles of biomedical ethics when we have a lot of those really tricky decisions that Tracy spoke about, it can help us with our dying patients and help them to achieve a good death.
So after hearing what Sister Fiona had to say to us, I want to have some thoughts as to what is a good death. I'll put up a few pictures just to prompt you and be keen for a few comments from the group. This is where we know who's been listening to you, Fiona. So any thoughts on what makes a good death? Very individual. Mm-hmm.
Having your family around you.
Family around you, very important. Mm-hmm.
A good life.
Mm-hmm.
Having your wishes respected.
Yeah.
Thank you. There was a national survey done and looking at what factors were considered important at the end of life. This surveyed about 1,000 people, and it was an equal representation of patients with a terminal illness, recently bereaved relatives and healthcare professionals. There were a lot of different aspects, but the common themes were control of physical symptoms, the patient being prepared for death and feeling ready to go, the opportunity for closure or sense of completion of the life. I think that's something around a good life and feeling it's time to go, it is my time. And interestingly, and we need to take responsibility, a good relationship with healthcare professionals. And we all know that's really important, but it just highlights just how important it is that we have a good relationship with our patients. And obviously we need to have that good relationship throughout their whole illness, but I think it's really important whenever they're actually dying. And the end-of-life care strategy states that how we care for the dying is an indicator of how we care for all sick and vulnerable patients. And it's a measure of society as a whole and a litmus test for health and social care services. So when we work in palliative care, I think we have a huge responsibility to make the dying phase of our patient good and also the experience that the patient's family will live on with good. So now we get to a wee bit of fun. Hands up who's told a lie. Thankfully, most people are quite truthful about that here. I'll not do what I did with my Sunday school class on Sunday and ask you to give examples of that. That was fun. But do we think lies are always wrong, or do we think sometimes it's okay to tell a lie? Here's a few thoughts. Lies are sometimes acceptable. Certain types of lies are more acceptable than others. It is acceptable to lie to prevent a person from harming himself. Lies of any form are wrong. Lies designed to ease the distress of the individual are acceptable. Has anybody any thoughts on any of those? I think as I read through them and reflected on them, I thought, what's the difference between telling a lie and not telling the whole truth? Is it different? Not sure. I think ahead to my summer holiday and getting off the boat at Holyhead, and when the boys say, how many minutes is it going to be till we get to Cornwall, meaning how many times do they have to count to 60 out loud, I don't think I'll be honest. I might not outrightly lie, or I might. But it's just an interesting thought as to, what we do with the truth with our patients. So I won't ask you to put your hands up, but who here has told a lie to a patient? Or maybe put it in a different way, maybe withheld the full truth from the patient, and is that okay to do? So I would like some examples. I have a few, but I would like some examples from you as to situations where we maybe have been tempted to, or we have maybe not shared the whole truth with the patient, and think about whether that's appropriate or not appropriate.
Thinking of a patient we had who was, she had never taken drugs in her life, and she refused to take painkillers, and because everything that she'd always had had been natural. So I was trying to convince her that morphine was from a natural product, and trying to convince her to take that. And took some persuasion, you know, but it was, and then she sort of, this is enough years ago, she actually couldn't tolerate the morphine, and we had to change her onto oxycodone, which wasn't quite so natural. So it was the same family as morphine, but so one of the ways to get her, that her actual pain became, you know, it's the only way we could get her pain under control.
Yeah. And going back to the comments before, you know, easing the distress of the individual, there was some reasoning behind allowing them to think maybe slightly differently to what we think about it. Any other examples anybody can think of?
Not telling a patient about the risk of having a massive bleed when there was a real risk of having a massive bleed, but so really not being economical with the truth as opposed to direct lying, but making a judgment that that would give them too much distress or worry about something which, if it did happen, would be impossible to come to terms with anyway, but that's how you justify it to yourself.
Yeah, and for that patient it might have been just too distressing. They might have focused every single waking moment until their death waiting for it, and that's not how you want them to spend their last days.
But it was still me being paternalistic and choosing to be paternalistic rather than having the conversation, so I don't feel proud of it either.
I think for some patients that's right though, but for some patients who want to know details, it's not right, and that's again our point of every patient is different. Any other thoughts?
I suppose that sometimes, you know, when you know a patient isn't that terribly well and they're focusing on, you know, still having treatment, and they're talking about getting themselves built up and to get themselves ready for the next treatment, when you know actually that that's not going to happen, but you don't actually go there with that conversation. And sometimes I'll pan it off and say, well, you've got an oncology meeting a couple of weeks down the line, or whatever, you know, so kind of not telling them a lie, but not truthful either.
And sometimes that can be a good thing because that maintains some of their hope, but we need to know then, we need the wisdom to know when it's right to then redirect their thoughts. I mean, it happens to us a lot whenever when patients may want to go home for terminal care at home, but the family have told us this is not an option. They will not cope with this patient at home, so we plan to send them to hospice with a view to getting home. And the patient has some hope that home will be there, but we know deep down in our hearts that that's probably not the case. But sometimes it's appropriate to let patient have retain that hope of that. But I think you can view that, and that could be either right or wrong, you know. And also we have our patients who have goals that are way down the line. You know, we have patients who we think have weeks to live, and they talk to us about looking forward to the birth of a grandson in 6 months' time. What do we do with that? You know, and sometimes we choose to correct them, but sometimes we choose to let them sit with that thought. And it is about working out when that's appropriate. Something maybe a wee bit easier to manage because we deal with it a bit more often is collusion. And we're all faced with that a lot. Imagine you're the person in the situation and you're the relative and your next of kin has asked for information to be withheld from you. How does that make you feel? Probably none of us would be that enthusiastic about that. But we do experience that a lot, so it's important to think of the relatives whenever we're dealing with that with the patient. And we all have the patient's relatives who come and say, "Doctor, don't tell Granny. She'll just turn her face to the wall and die. We know her best." What do we do in that situation? So here's another opportunity for a few examples. I'm sure we've all experienced it. If anybody wanted to share a couple of examples of a situation and what we would do about it or have done about it.
You know, don't tell. First of all, we don't want you to come out and you're in that treatment. So then, you know, say, well, I'm coming in my own clothes, so it's not a uniform. So, but no, I'll not cause any handlings. I'll not go directly in. However, if I'm asked, I will have to talk around it, but I'm doing my best not to cause any distress. And ultimately, the person in question has known, there's been language used in the hospital that has led them to believe they've had cancer or a life-limiting diagnosis. So they managed to navigate the communication without causing any distress to either family or patient. Wee bit of collusion with both, without telling the whole truth and without causing any harm, you know, avoid a bit of stress.
And you're balancing everybody's needs there.
Yes.
Yeah. Yeah.
Often the patient themselves knows what they don't want to know. You know, and you can ask questions in such a way that you know the patient does not want to hear anything, and that's fine. That's not collusion, because you have given them the opportunity, and in fact the family are very well aware of Granny's needs and desires. That happens very often. But if you're asked specifically, you're going to tell them. You know, if it's a direct line of questioning, but normally it's not. Normally it is a softly approach. But family quite often has a good idea. Sometimes they don't. But if you're there one-on-one, you can get the bank and you can tell them what needs to be told.
And it's important for families to know that if we are asked directly, we do have to be honest.
Very much so.
But I mean, we've all had situations. I've had many clinics where I've been whisked away by the family on the way into the clinic and warned, do not tell. And it's a very difficult situation to be in, because you can see where they're coming from, but at the same time, we need to be honest with the patient if they do want to know. I just want to read to you a bit from the GMC book, because I think where we do have difficulties in this sort of situation is whenever the patient needs to know because they have to make a decision. So for example, you know, we don't want to tell Granny that she's got cancer and bony metastases, but actually the bony metastases is causing her significant pain, and if we tell her about it, we can offer her radiotherapy and it will help her pain, but we can't give her radiotherapy without telling her she's cancer. So in that situation, sometimes we just have to tell the patient because it has impact on their treatment. And this book by the GMC, Treatment and Care Towards the End of Life, states, "You should not withhold information necessary for making decisions, including when asked by someone close to the patient, unless you believe that giving it would cause the patient serious harm." And in this context, serious harm means more than just that they might become a bit upset. So we just need to be careful that we do actually talk to patients whenever they actually need to know. And we also have patients who are going to hospice, and the families will say, "Don't tell them they're going to a hospice. How can you send them to a hospice and not tell them what it's called?" You know, now we can do it in a soft way. We can, you know, we can tell them about it and not be very clear, but they do need to know where they're going to be. Okay, I'll pass over to Caroline.
So life-prolonging treatments in patients with advanced malignancy is probably one of the stickiest areas that we come into contact with, and certainly Tracy and I both work in Craigavon and Daisy Hill as well, and it's frequently what we're asked to be involved with when we attempt to make decisions in this area. So how do we define life-prolonging treatments? Well, it's any medical intervention, any procedure, any medication that is administered with the purpose of benefiting the patient but forestalling the moment of death. So that could be artificial ventilation, it could be artificial nutrition and hydration, it could be CPR, it could be hemodialysis, it could be antibiotics. And usually when I'm asked to see patients in this area, I ask two questions. A, can we do it? And usually in a hospital setting, we can do it. And even if a patient is in a hospice setting, we can transfer them out and a hospital will do it for us. So usually the first answer is yes, so that's not really helpful to me. But the second question is, should we do it? And that's where it gets really difficult. And if we should do it, I'm assuming that it's not a futile process. So how do we define medical futility? Again, we're back into the areas of grey. Different people define it in different ways. Some of the ways it has been defined is a patient's given a lethal diagnosis or prognosis of imminent death. Somebody has got widespread, rampant, rapidly progressive malignancy. Is it helpful to offer them any treatment because we know what the outcome's going to be? Is medical futility a treatment if it can't achieve its physiological goal? We know that CPR is extremely unsuccessful in patients with advanced malignancy, so it's not going to achieve its physiological goal. So is it futile to offer it in that situation? A therapy that cannot achieve a patient's or a family's goal. Patient maybe has lung cancer affecting a lung, but it's spread somewhere else, and the family or the patient wonders, can you not just take the lung away? Can you not just take that piece away? We know that's futile. A therapy that cannot enhance the patient's quality of life. Sometimes we have patients who could potentially be offered chemotherapy, but we know it might increase the length of time that they have, but it won't increase the quality of that time. So is that medically futile? Or is a therapy that will extend a patient's life by only a few days? Is that futile? For some patients, yes, prolonging the dying phase would be a very bad thing to do. For other patients who maybe are waiting for relatives coming from abroad, who are waiting for babies to be born, maybe those antibiotics, that blood transfusion for treatment of a calcium would be the right thing to do. So again, we're still in the grey. I'm going to take out two areas which probably we're asked to be involved with quite a lot or have to make decisions with. First is resuscitation. So a few facts and figures. It was developed in the 1960s and it was intended for sudden cardiac arrest. And there were very clear positive predictors. These were patients who previously had been fairly fit, maybe had had a heart attack, were in a hospital unit attached to a monitor. They had a rhythm which was shockable and they received defibrillation. And that's what it was intended for. So in those patients, the in-hospital success rate of restarting heart and breathing is about 4 out of 10. But what is real success, patients who are maybe surviving to discharge, it's 2 out of 10. But in our patient group, in patients with advanced cancer, the success rate is much less than 1%, and even lower in hospice environments where there aren't necessarily lots of high-tech resuscitation equipment. So there was such concern at how CPR was being portrayed in the media that, you know, this is a fairly old paper but still very relevant. The New England Journal of Medicine looked into it and looked into lots of different medical television programs. They looked at ER, Chicago Hope and Rescue 911. No idea what that was, but it was obviously in the mid-90s. And in 97 episodes, there were 60 examples of CPR, and 65% involved children, teens or young adults. So again, not the population that we see. And out of that, 3/4 survived the arrest. So we know 4 in 10 in real life, but on television, 3/4 survived the arrest, and 67% survived a discharge versus 20% in hospital patients, and versus the less than 1% in our patients, in those patients with advanced malignancy. So when we have an issue about resuscitation, how do we apply the ethical theories that we talked about before? Well, if we think about autonomy, would we involve a patient in the decision? Should we do that? And I think a lot of the evidence that's coming forward at the minute is that we should, unless we can demonstrate that it would cause psychological significant harm or distress to the patient, and it's hard to do that. Or should we involve families in these decisions? Beneficence. Could we do good by doing CPR? Well, very small chance that it could be successful. But it might be doing a better good to actually not subject a patient to CPR, to not have the family excluded at the moment of death, to not put the patient through the risk of broken ribs and the trauma and the lack of dignity that's involved in a resuscitation attempt. So that again comes into the non-maleficence to the harm. And then we have to think about justice. If we have patients in acute hospital wards who are for resuscitation, who we know have virtually no chance of success, and their heart stops and the resuscitation team is called, that means that resuscitation team is not down in A&E with a 35-year-old father of 3 who's come in with EMI. So we have to think about that. So that's how, when we have any of these difficult decisions, and certainly it's what myself and Tracy do in our practice, if we don't know what to do, we go back to those 4 principles. Involve a patient, can we do good, can we do harm, and how do we balance our patient's needs with everybody else? So why is there controversy over artificial nutrition and hydration? Why is a PEG tube and why are fluids controversial? Food is love, fluid is love. I became a mummy a few years ago. When my daughter eats well and drinks well, I feel fabulous. So that's ingrained in us, that naturally comes from all of us. And our friends in the media haven't helped us either. The patient who's left to starve, who's left thirsty, who has to drink out of flower pots to keep the hydration up. So that's why there's a controversial issue. So what do we have to consider when we're faced with this? Again, it's very similar to our ethical principles. Can it help the patient? Could fluids help the patient? Absolutely. Might make the patient feel a bit brighter, might help with thirst. Not a lot of evidence of that, but it sometimes does. It might help the family, and maybe that's very helpful if that's going to be a stumbling point in their bereavement. Could artificial feeding help a patient? Yes, in certain circumstances, but not all, and certainly not in patients with very advanced, rapidly progressive malignancy. Can fluids harm people? Absolutely. Lots of needles, damage to the skin, fluid gathers in people's lungs. Can feeding harm people? Yes. The natural part of a dying process is that our appetite goes down, that we eat less. If we fill patients up with a lot of artificial food, we can make them feel sick and bloated and uncomfortable. Sometimes there's a benefit to a trial of treatment, particularly with fluids. Again, to make sure it doesn't harm the patient, can it bring any benefit, and can it bring any comfort to a family who maybe feel that allowing the patient to have artificial fluids is part of love, is part of looking after them at the end of their life. Can it maintain hope? Hope is very important if it is realistic hope, but false hope, as we know, is very damaging. Can it prolong death? Palliative care has always been very clear in the outset about what it's about, that it certainly is not about hastening death, but it is not prolonging the dying phase, it is not prolonging suffering, and we wouldn't want to do that. And often it's very important to determine at an early stage what the limits of treatment are, what is the ceiling of treatment. So through all of that, what is the most important thing? And I know we're in election season, And I go back to Tony Blair's speech in the 90s. He was education, education, education. Mine's different. Communication, communication, communication. If we keep the patient at the centre of what we're doing, at the centre of the decisions that we make, if we bring the family with us, because it's the family who will be left in bereavement, and it's the family who will come after us if we get it wrong. If we use our ethical principles to each difficult situation we have, and we keep talking to everybody, and we let the family know this is really tough, and we don't know what the right thing to do is, and it is a grey area, and they can see our humanity, and they can see our concern as well, that helps. It helps enormously. Max and I wrote a chapter for a book a number of years ago, and he preceded the chapter with this statement, and I come back to it all the time. I find it really helpful. We must refrain from doing things merely because we know how to do them. And that's back in the 50s, so good practice. It's not new.
That is why, even though we know how to treat dehydration, we know how to treat an infection, we know how to do CPR, that we need to weigh up whether it's always right to do it. And the challenges of that highlight why we've had all this training and experience in it, but do we feel confident in every situation we come across? We don't, because every situation is different, and we have to weigh up every individual situation with that individual patient's needs. So the good physician treats the disease, and the great physician treats the patient who has the disease. And that's where good judgment and communication comes into it. It's not just about the medical treatments. That's the book that I showed you earlier, certainly worth a good read. It's very informative. And just to finish off, if you have any questions, we probably won't have the answers based on what we've just said, but we can certainly weigh it up, discuss it, and come to the best answer.